Jonathan Kanter is the former Assistant Attorney General for the Antitrust Division at the Department of Justice. He was the top DOJ antitrust official in the Biden administration for the past 3 years before leaving the agency in December. For more than 2 years, STAT has been investigating United Health Group, the largest healthcare company in America, over its use of technology and denials in Medicare Advantage, as well as its growing empire of physicians and providers. STAT spoke with Kanter to talk about the biggest antitrust issues plaguing the healthcare industry. This could be anything from monopolization of certain markets and how it affects everyday consumers and doctors. And many of these relate to United Health and the way it has evolved over the past 2 decades.
A great place to start is in November, while you were still the top antitrust official at the Department of Justice. You gave a speech that called for policymakers to, quote, fundamentally redefine our approach to antitrust and competition policy in healthcare. It was interesting because you framed the problems with our healthcare economy as a moral problem. So can you explain the immorality you see in our current system?
Sure. I mean, I think if we're not taking care of each other, then that's a moral problem. When people are not getting the health care they need in order to live healthy, long lives, when people's loved ones are not able to access high quality health care, even though it should be available and is technically capable, that's a moral problem. I think as a society, we have an obligation to make sure that we are taking care of each other and taking care of our own.
You also called our system of caring for older adults a national failure, and we'll get into more of that. But what has gone so wrong in the care of older Americans, and how do concerns about monopoly and monopsony power play into that?
Well, I think this factors into a lot of the issues that I addressed in my remarks that day. Many of our issues that we're confronting in our healthcare system relate to Medicare and Medicaid, relates to Medicare Advantage. It relates to this sort of hybrid public-private system where I think there's been many allegations, at least, of upcoding and allegations of conflicts of interest and moat building. And that's against the backdrop of, many conversations I know that I've had and others have experienced where healthcare professionals feel like they don't have the freedom to provide the level and quality of care that they want to their patients. And you often hear about this being most acute in the context of older Americans who are often least capable of taking care of themselves, whether it's financially or in terms of their support networks, or frankly, even their physical ability to seek out care and persevere through a very difficult and bureaucratic system.
You mentioned you had conversations with people. Who were some of the people that you talked with? What did they say? Just kind of curious for some of those on the ground things that you heard.
Yeah. So one of the things that we've really tried to do at the Department of Justice during my tenure was expand this conversation to include not just inside the Beltway people who are consider themselves antitrust experts, but go to the people who are also affected by the work that we do. And that, in the context of agriculture, might mean talking to farmers. In the context of tech, might be talking to startups and tech entrepreneurs, reaching out to consumers and people who are directly affected. But in the context of healthcare, I mean, there are a lot of different stakeholders. First and foremost, there are patients and patients groups and advocacy groups, and we've spoken to them at great length. But there are also stakeholders, including caregivers and providers, whether it's doctors, emergency room physicians, nurses, technicians, labor unions. I think it's important for us to have, if we're going to have an effective antitrust enforcement policy, competition enforcement policy, and frankly, healthcare policy, it's important that we engage with all relevant stakeholders, not just a small corner of the ecosystem.
I want to go back to the speech because it was one of the more consequential healthcare antitrust speeches in recent memory, at least that I can remember. And there was, a big thrust of it was, you warned about the dangers of the platformization of healthcare. And I want to read another excerpt from there. He said, America's largest healthcare companies are no longer just health insurers or pharmacy benefit managers. And they are no longer just doctor groups or hospitals. They are all of the above. Meanwhile, consolidated health markets have failed to deliver on the promise of better care, lower prices, and increased access. Instead of increasing efficiency, healthcare platform integration and annexation has created perverse incentives, conflicts of interest, and opportunities for self-preferencing and self-dealing. Now, this speech also came on the same day that DOJ sued to block United Health's acquisition of the home health and hospice conglomerate Amedisys. So I'm curious, to what extent was this critique directed at United Health Group?
Yeah. So even though I'm no longer at the Department of Justice, I can't speak to issues that were active during my tenure. So I'm going to hold off making any direct accusations or connections to specific companies. But let me say this, which is in antitrust in our world, we spend a lot of time thinking about technology markets. And for over 10 years now, we've been experiencing and developing antitrust policy to deal with technology platforms. And these are multi-sided entities that have extensibility. They serve multiple communities at once. And often they run a platform and they also compete on that same platform. And what I've observed and what I discussed in this speech is that many of the same characteristics that have both defined those technology platforms and created antitrust issues and resulted in the kinds of concerns that have become widespread regarding big tech are now present in big healthcare. And one of the concerns, one of the many concerns that I discussed in that speech is how healthcare companies are no longer just competing at one level of the supply chain. Right. And so we used to have a world where hospitals competed with other hospitals and physicians groups competed with other physicians groups, insurance companies competed with insurance companies, and so on and so forth. That's just not what we have anymore. In order to compete at one level, you have to now compete at scale almost at all levels. And you have a situation where, the largest insurance company in the country is also the largest healthcare provider in the country and also has PBMs and technology. And that if you want to be a part of the system, whether it's as a patient or as a doctor, a nurse, a pharmacist, or an insurance company, you have to plug into at one level or another to these platforms. And what we see are large moats that protect these platforms. We see multi-level entry barriers to entry, meaning, again, if you want to compete at one level, you have to compete at all and often at scale. And then you have conflicts of interest that exist throughout the system, so that if you're on both sides of a negotiation, it creates a system where you're trying to maximize revenue and profitability for the enterprise as a whole, rather than be a fierce advocate for whichever side of the system you're on, whether it's the patient, the physician, the insurance company, the pharmacist, the pharmaceutical company, or whomever. And I think we are at a real risk that this sort of platformization concept will result in markets tipping throughout our entire healthcare system to a very small number. And by very small, I mean one or two companies that have a massive amount of power control with a small number of also-rans lingering about.
It seems like this also gets at how you said antitrust officials have been playing healthcare Tetris in terms of how they've been analyzing some of the different healthcare deals over the years. Can you explain that a little bit more and how that's contributed to some of the things you just talked about?
Sure. So this is, again, another issue that we've experienced throughout the antitrust community, which is that the sort of geometry of markets has become the prevailing lens through which people have viewed antitrust enforcement. So that, again, we think about or have thought in the past about competition that against the construct under the constructs of vertical and horizontal. Right. And so competition occurs horizontally, meaning a hospital just competes with a hospital. Or there's vertical integration, which is a term that was really developed, in mid 20th century to talk about, the suppliers and distributors and factories and retailers. And what often the assumption that comes along with vertical integration is that by integrating, you become more efficient. And I think that kind of geometry has led us astray, because markets are far more complex than just being these sort of two-dimensional Tetris games of vertical and horizontal. Instead, they're more nuanced, they're multidimensional, they're multi-sided, and they're more platform-like, meaning that different sides of the ecosystem have to plug into the same corporate entities at different levels. And again, those entities are often not just servicing one side of the market, but they're servicing multiple sides of the market while at the same time competing against entities that they serve. And I think that creates all of these kinds of nuanced three-dimensional dynamics that I think we miss if we look at the world through two-dimensional horizontal vertical lens.
So the vertical integration part is important. And again, if you compare horizontal, it's where, for example, a hospital competes with a hospital. That's the horizontal side. And then vertical, you're saying, is the companies, if they decide to buy each other, they actually maybe do business with each other. And instead they're all falling under the same corporate parent. Is this kind of history repeating itself in healthcare a little bit? Maybe not in healthcare, but just writ large, because I mean, in some of our reporting, with United Health in particular, we saw parallels with Standard Oil, where there were large conglomerates back in the day where they kind of took over a single industry and in some ways vertically consolidated. They were the buyer and the seller in a transaction. So are we kind of repeating some of history with these different modes of consolidation?
Absolutely. I mean, if you look at the creation of the antitrust laws, they were designed to deal with these trusts, which were these entities that had massive amounts of control and power throughout the economy, and often had exactly these same kinds of characteristics: conflicts of interest, vertical integration. I think those issues are exacerbated in the context of multi-sided markets and platforms, and when you start adding in technology. But let me give you an example, and this is something I discussed in my speech, which is that, let's say you have an in-home, an insurance company owns in-home healthcare provider, and that in-home healthcare provider is now going in a context of Medicare Care Advantage, going to see an elderly person in there, an older person in their home. At least there's been a lot of reporting and discussion about how the more they are coded as being having ailments, the more money the insurance company can recover. And then on the flip side, there's an incentive for an insurance company to be as efficient, I say that in air quotes, as possible when treating those ailments. And so you see how these kinds of conflicts of interest can start to take hold. And again, even setting aside whether there's bad behavior going on, and I'll leave it to others to make that determination. What I would say is that I think as antitrust enforcers, as an antitrust community, as an economy, as a society, when we see those kinds of conflicts of interest, it at a minimum generates suspicion. And I think there's a important discussion that we should have as a society about whether those conflicts of interest, particularly in healthcare, are something that we view as advisable.
I want to go back to United Health, because we've reported on how they've become the largest operator of physician clinics in the country, and specifically how the companies use that sprawling network of medical groups as a way to boost revenue through coding, which is what you were just talking about. This is especially the case in Medicare Advantage, the government program that pays private insurers like United Health based on how many codes and diagnoses its enrollees have. Can you explain again why you think that's a conflict of interest in this instance? A company having this large network of physicians that are the epicenter, they are the grounds, they're the means for coding those diagnoses in one of your largest insurance programs.
Yeah. So when you think about in-home healthcare, I think most people in society think about, okay, someone's going to come to my house or my apartment, and they're going to take care of me, right? And that's particularly valuable when you have an aging population who may have difficulty leaving their homes in order to get the care that they need. I think that's different than a lot of the experiences or a lot of what in-home healthcare providers offer, right? A lot of what it is more like lead generation, which in terms of, okay, how do we basically get new um, people into our system? How do we intake patients? And when we intake those patients, how do we do it in a way that's as expansive as possible so that we make sure that all of their ailments and issues are properly um, noted and coded. And that is particularly important in the context of Medicare Advantage because those codings are, as you know, linked up to reimbursements. And but in many instances, these in-home healthcare companies are not necessarily caring for these individuals. They're diagnosing but don't have diagnostics. Sometimes they do, sometimes they don't. But really, it's more about onboarding the patients. And I think again, I think that does raise questions about well, what are the financial incentives if the Medicare Advantage insurance company effectively or provider services company is also owning the in-home health provider that is coding on the front end.
And it even goes beyond the in-home health, because I mean, you have companies like United where they own actual physician practices, the surgery centers where people go get care. They might get coded, and that's where a lot of the interactions are. That falls under the same conflict of interest that you're talking about, right? Where someone goes
Yeah.
into their doctor's clinic and they don't even know that that doctor's clinic is owned by the same company that also happens to be their Medicare Advantage insurer.
Right, exactly. And those clinics might be competing with non-vertically integrated clinics, which creates additional conflicts of interest on the insurance side. But this is, where the horizontal or the kind of Tetris-like issues come into play, because for decades in the antitrust world, what we were discussing often was, okay, do we need more consolidation among hospitals or in order to get more doctors, physician groups to get more leverage against insurance companies? And do insurance companies need to merge in order to get more leverage against providers? And it was sort of this race to the bottom. But that's an outdated framework. Now the concern is not that one has too much leverage over the other. It's that now they're maximizing their take rate as an intermediary across the entire continuum. And if you talk to most physicians and nurses, they used to be small business owners who would care for their patients and also develop small businesses and become embedded in their communities. This was particularly important in rural communities, and where often you'd have generations of doctors who knew generations of patients and their family histories. And, we see kind of the depersonalization of healthcare. And we also see a world where health providers are now no longer small business owners, but more often employees. And, talking about unionizing and other concerns in order to address what they view as a lack of not just compensation for their work, but the lack of freedom to make decisions that they believe are appropriate for their patients.
I want to hit on something that you just said. You mentioned how, in some instances, these large companies, these health insurance and service conglomerates, they have these medical clinics, which also happen to be competing with others. And you said that creates issues from the insurance side as well. Can you explain that a little bit more? Is that about the insurance company excluding medical practices that it doesn't own in terms of its insurance networks? Can you expand on that a little bit?
Yeah, these are issues that come up in the context of antitrust and healthcare frequently, which is that the issue of steering patients to owned and operated clinics, for example, or it's usually not binary. It's usually not about having all access or no access. It's usually more about what are the reimbursement rates like to non-affiliated or owned and operated providers. What are the bureaucratic or red tape barriers that are put in place, or other tactics or techniques that might disincentivize, raise costs, or make it more difficult to participate in a health platform unless you are completely owned and operated. which again creates this race to the bottom where in order to compete, you kind of have to be at all levels, have it at sufficient scale, and have these kind of closed networks.
Companies like in United Health in particular, they did not take control of these physician groups and providers overnight. This is kind of a very steady development over the past 10, 15 years. And in fact, the Affordable Care Act has encouraged vertical consolidation among insurers, hospitals, and other companies that are trying to get scale. Can you put a finer point on it, on how vertical integration is affecting everyday Americans out there who are getting care, as well as other companies that are trying to compete with companies like United, that have consequently become so much larger through these vertical integrations?
Yeah, well, I think the healthcare system is complicated, right? You report on this every day, and to suggest there's one silver bullet to fix the system, I think would be naive. But I can offer a few observations in terms of where I think some of these vertical integration and sort of this march onto vertical integration has had repercussions for the public. So you're right, it hasn't occurred overnight. What has happened is we've seen decades of mergers, and sometimes the mergers are big, sometimes they're small. But one of the problems I think we've had in the antitrust community is that it's the disaggregation of these transactions so that they're viewed each in a vacuum. But when in reality, what you have is this long-term strategy to roll up industries and consolidate and concentrate. And then markets, tip gradually over time rather than overnight with one single transaction. The body of work in terms of the mergers in the aggregate that have an outsized effect versus the impact of any one transaction. And so I think we had a system that was not sufficiently attuned to this kind of roll up or gradual march toward consolidation. And I think in order for us to be more effective as enforcers, we need to think about, okay, well, what is the aggregate effect of consolidation? And what is the cumulative impact of each individual transaction against the backdrop of the other? And that kind of leads to the repercussions from the public, because these conflicts of interest start to become more profound and more powerful the bigger you get, right? Because the more money you have to maximize an arbitrage on all sides of the market, the fewer opportunities or the harder it is to compete at scale, unless you're at multiple levels, which means now it's harder to have an independent pharmacy, or it's harder to have an independent physicians group, or it's harder to have just a standalone insurance company, or whatever it might be. And I think that results in fewer options and leads to all of the kinds of things that people are experiencing, including more bureaucracy, harder to get the kind of personalization of care that I think we believe is appropriate in a modern healthcare system.
In terms of antitrust enforcement, I remember 10 years ago when Anthem and Cigna and Aetna and Humana, the big health insurers, were trying to merge, and those were quickly challenged by DOJ, and honestly pretty obvious to challenge. But you mentioned like maybe it's sometimes it's the smaller deals, the ones that fly under the radar, like a lot of these deals that United Health and other companies have done to build up this massive base of physician clinics, for example, or surgery centers. Are those the ones that they fly too far under the radar and have gone unchallenged? Maybe they don't meet certain thresholds that should have been challenged. Is this a failure of antitrust enforcement? Is this government not having enough resources to challenge enough deals? What's your take on that?
Yeah, it's probably a mix of everything you mentioned and more. I think the antitrust enforcers, are extremely well intentioned, extremely skilled, and care deeply about making sure they protect competition in the healthcare system. I think the system of antitrust enforcement had developed against the backdrop of this kind of geometric framing of vertical and horizontal, which we discussed a little bit. But it also developed against the backdrop of one where it became very difficult and costly to litigate every transaction when you have, the agencies are often looking at thousands of deals a year and may be looking at, hundreds of deals in the healthcare space. And so how do you, as an enforcement authority, manage all of those at once with scarce resources? And just to put it in context, at the antitrust division, when I started, we had, I think, about roughly 350 fewer people than the antitrust division had in 1979. And so we are, extremely under-resourced. And that's against the backdrop of a massive economy and with significant issues like in areas such as healthcare. So how do you use your resources effectively and prioritize them? And one of the things that I was really trying to get across with my speech about platformization is that if we need to start with market realities and work backwards. And so instead of trying to fit facts into models that might have horizontal or vertical or have these kind of structures that were more common in the last century, we need to start explaining how markets actually work. And if the issue is we have a platform that has, and that the competition concerns deal with the kinds of issues that you confront in a platform, multi-sided platform market, in terms of moat building and conflicts of interest and multi-level entry requirements at scale, then when analyzing mergers, whether it's an individual merger or a string of mergers, it's important to think about the consequences from a competition perspective in light of those market characteristics, which might give us the tools to be more effective in how we think about, for example, challenging an individual transaction or bringing an action that challenges multiple transactions in the aggregate, because the aggregate effect is greater than the impact of any one single deal.
So in your mind, going back to horizontal versus vertical, do you think vertical integration in healthcare has been a mistake? And I ask that because the FTC and the DOJ, they really haven't challenged many deals on vertical grounds. Even if you look at the DOJ's lawsuit against United Health, a lot of the issues involve wage markets and also the horizontal overlap between United Health's existing home health base. There's not a specific argument against vertical consolidation, but I want to ask you, has vertical consolidation been a mistake given the platform issues that you've been raising?
Well, I don't see this. I guess what I'm trying to convey is, I don't necessarily view platform issues as vertical. And this is something that I think during my 3 years and a few days at the DOJ really tried to develop new tools and frameworks to help identify why, for example, platform issues or entrenchment is different than traditional vertical integration. And that's something that we articulated in our revised merger guidelines in 2023. And we have started building out those tools. We've also started bringing monopolization cases in a wide range of industries, whether it's concert tickets or smartphones, real estate software, among others, that start to recognize these market realities, that multi-sided platforms and flywheels and moats and all of those characteristics are more appropriate framework for analyzing these kinds of market characteristics. And with my speech in Pittsburgh, what I was really trying to explain is that I think those are the right frameworks or important frameworks for us to deploy in the context of antitrust enforcement in healthcare.
There's another interesting part of your speech that I want to call out. And it was when you talked about regulatory gamesmanship and how some companies like United Health circumvent the regulatory environment. And there was a good example, the medical loss ratio, which it's the regulation that says health insurers must spend anywhere from 80 to 85% of premiums on actual medical care, at least for the fully insured side. Now, we've also reported how United Health's insurance subsidiaries pay its own physician groups higher commercial prices for many types of services, which essentially allows United Health to shovel money from one side of the company to another and kind of meet those MLR regulations. And that was kind of referenced in your speech. In what ways does this distort healthcare markets, and is this anti-competitive?
Yeah, listen, these are specific questions I won't address in connection with any specific company or practice. But let me take a zoom out a little bit and try to frame it for you, which is there are different kinds of constraints on the ability of companies to exercise market power. And in some industries, those constraints come solely from competition. For example, one store might be next to the other, and the other store offers a lower price, and then you try to match that. But you have to understand market realities in any market, and regulatory structures are market realities, right? And so the medical loss ratio was written really, I think, with a concept of this sort of horizontal competition, right? Thinking about business units in a vacuum. But medical loss ratio is supposed to be a constraint against the ability of, for example, an insurance company to maximize its take rate. And to the extent that engaging in market structure changing transactions or conduct can allow companies to circumvent some of those regulations and raise barriers to entry in the process, it has the same competitive consequences of other kinds of behavior. And so what should have been a constraint on the ability to extract monopoly power and prices and take rates is now circumvented due to the vertical integration or platformization.
Yeah, and a lot of that makes sense. And so have you and your department noticed more instances of these, vertically integrated companies or companies with different components owning both the payer and provider, more instances of this MLR gamemanship?
Yeah, I think that's a question. I'll leave to the department to address in due course in the context of its investigatory work. I think you've reported on at least and just discussed questions about whether that's occurring. I think if my goal is to raise awareness about the kinds of questions as a society we should be asking to make sure that our healthcare system is working, and also to explain what I view as the dangers of platformization of healthcare. And I think one of those dangers, which I identified in my remarks, is that it can create opportunities to circumvent regulations that are designed to constrain the ability of companies to exercise monopoly.
I think I know the answer to this one, but I have to ask it anyway. I just want to know if you can confirm that DOJ is investigating United Health Group over the relationships between its various subsidiaries that do business with each other, like United Healthcare and Optum.
Yeah, unfortunately, I can't confirm or deny any investigation at the Department of Justice.
Okay. Let me see if I can ask this then. Since the lawsuit with United Health and Nemesys is public, is there anything specific about that deal that you find most concerning? Because again, the DOJ did not challenge it on vertical consolidation grounds, but there are other very interesting antitrust components to that case.
Yeah, I'll refer to that transaction only based on what's publicly available. It's an active litigation, and I don't want to do or say anything that would interfere with that process. But I can, I will point out, because it's in the public filings, that there's an important element of that transaction which relates to the impact on skilled nursing, for example. And I think one of the issues that we talked about early in our discussion today is how people who provide, who offer healthcare and care for patients for a living, are feeling squeezed, and squeezed in terms of their ability to realize adequate compensation and their ability to provide the appropriate level of care for their patients. And I think those are issues, at least conceptually, if not, or both conceptually and specifically, that we addressed in our lawsuit.
We now have a handful of publicly traded health insurance and services giants. United Health Group is just the most largest and most visible example. What policy actions need to be taken to address this and some of the issues that we've talked about today? Is this an instance where policymakers should consider breaking up these companies? Is that realistic? What are tangible solutions here?
Yeah, I think all options should be on the table, but I guess what I would say is we can't have I think in order to have a constructive conversation, we need to start with a common understanding of today's market realities. And if we are stuck using constructs that reflect the way the markets looked 20 or 30 or 50 years ago, we're never going to have the kind of productive, constructive conversation about how to fix the problem if we can't diagnose it in the first place. And so I think I guess the point I want to start with in this conversation in my speech, but is with a great deal of urgency, making sure that we are understanding and discussing the problem in terms that actually reflect the way markets are functioning. And to me, the economics, the market realities are far more platform-like than they are two-dimensional vertical integration. And I think the sooner we can start coming up with a taxonomy and a common way of talking about the problem, the sooner we'll start innovating and developing solutions, whether they're enforcement-oriented, regulatory-oriented, or commercially oriented, that actually helps address some of these issues.
Okay, so let's assume that everyone gets on the same page and identifies and talks about the markets with with the same common language. So you're saying it could come from anywhere. You're saying it could involve antitrust enforcers trying to break
Yeah,
up these companies.
I think antitrust has an important role to play. I mean, competitive markets are, competition is necessary for a healthy market, and so we can't have a competitive market unless there are opportunities for people to compete at all levels of the ecosystem. And so I think antitrust is an extremely important role to play. Again, at the same time, I don't want to be naive. Healthcare is this massive, complex system that I think is beguiling and overwhelming to so many people, whether they're professionals who offer products and services and care, or people who are receiving it. And it's going to take a lot of work to get it on the right track. But I think antitrust is an important, competition policy is an extremely important ingredient in the recipe for how to solve it.
What other parts of healthcare, be it hospitals, pharma, medical devices, technology, I mean, you name it, what other parts also present concerning antitrust behavior from what you've seen, during your tenure?
I'll just make the observations. I mean, there are a lot of areas that are receiving attention, and some of those areas include PBMs, where the FTC is undertaking a number of studies and works. I think pharmaceutical drug pricing is something that is obviously on the minds of the public. There are many others that I think are ripe for discussion. I think as we see AI, generative AI, and other forms of algorithmic tools and services taking hold in healthcare, I think on one hand, it could provide really great opportunities to improve outcomes and innovation. But there's also a very real danger that if there's not enough competition and if there aren't sufficient rules of the road, that it could be used to further depersonalize the delivery of healthcare and perhaps make us even more subject to faceless algorithms making decisions about the course of care and further removing decision making from the providers who are in the examining room with patients.